Good morning. Why don't we get started? It's my pleasure to introduce Sammy Shukrallah. Sam grew up in Houston and did his medical training down in Texas, as well as his residencies in Vanderbilt and Alabama, and then did his cardiac training at the University of Minnesota, where we had the opportunity to see him, enjoy working with him, and participate in a small way of teaching him. And then he went down to the Ohio State University Medical Center for 3 years, where he was a very active member of the lung and heart transplant program and was the director of the EXHAL program. And then we were able to steal him back up to the cold north. So, and he's been here since this past summer, and it's been a delight to work with and an important addition to our group. And so Sam's going to talk about minimally invasive surgeries. Sam?
I feel like when I was taking my boards, I'm bringing my notes because for somehow it's like a crutch to me. Anyhow, well, thanks for having me. Can you hear me? Yeah. All right, so good morning, and the title of my talk is really, is it necessary to think about minimally invasive procedures? So an outline of what we're going to be discussing is kind of the benefits and the drawbacks, what are the indications. We'll review some of the larger meta-analyses and reviews, look at some of their results, and then talk briefly about how we move forward in building surgery. So I'll first kind of take you on a journey of how I became interested in this. In 2006, when I started my general surgery training at Vanderbilt, Michael Petrasic, and now at Terrence Apsey were performing mitral valve, minimally invasive mitral valve surgery through a thoracotomy using cold purgatory arrest. And while the nuances of what they were doing as a general surgery resident were cool and complex to me, I didn't understand the intricacies, but what I did understand was the post-operative recovery of these patients, because as the ICU resident, you had to take care of them. And overwhelmingly, these folks had three commonalities. One, they didn't have pain, they had less pain, they ambulated much quicker than their counterparts, and they bled less. So I kind of took that and buried it in my head as one of these nuggets that I look back on. I started my thoracic surgery training, and roughly about a year later, I went to the AATS in Toronto, where one of the keynote speakers was Patrick McCarthy, the chairman at Northwestern, whose title was In Defense of the Sternotomy. Oops, that's not true. So his title was In Defense of the Sternotomy, and while the details of this presentation escaped me, some of the main points of why he transitioned from a sternotomy to a thoracotomy and then subsequently back to a thoracotomy was primarily due to training. And from the audience stood a physician from Heidelberg, Germany, and made the following point and then asked the subsequent question. We no longer perform open fundoplications. Our residents are trained in laparoscopic fundoplication. Why are we not capable of doing the same in cardiac surgery? So briefly, Invasive is essentially surgical treatment for regurgitation and hiatal hernias, and this operation is particularly challenging because of where the esophageal hiatus resides. It resides very high up in the epigastrium, and it's quite difficult to get to. In fact, it is the only operation that I know of that has a retractor that is anchored on both sides of the bed. It's called the upper hand. And the reason it's anchored so sturdily to the bed is because you have to put two arms and retract this epigastric area to get to the hiatus. The liver has to be mobilized. Eventually, you mobilize the stomach to create a route. But we no longer do this. Now we fan about we fan about 4 trocars across the abdomen with a video scope, and the visualization is fantastic. The resident is trained by an attending that's standing in the corner and watching what he's doing on the video scope. And this is standard. If you would to poll some of the folks that did general surgery in here, if I were to ask Carl, for example, I did close to 27 as a general surgery resident. I've never done an open. And so anyhow, yeah. You remember the upper hand? Anyhow, so after finishing my fellowship, I went to Ohio State and started participating in the the lung and heart transplant team, along with mechanical circulatory support. And it was within these two silos, if you will, that I began thinking of minimally invasive mitral valve surgery, and I'll show you why. So when it comes to right heart transplant, we make a right anterior thoracotomy. It is the same exact incision that you would use in minimally invasive mitral valve surgery. It's the same exact one. This next picture that you see, the native lung has, the native lung has been removed, and what's left behind are the cuffs, the stumps of the pulmonary vein, pulmonary artery, and airway. And so when the allograft is sewn onto the recipient, we begin by sewing the airway, and then this cuff has to be sewn to an atrial cuff, and that is only done by mobilizing Sondergaard's groove. And guess what? Again, this is the same exact mobilization that we utilize when it comes to entering the left atrium to perform surgery on the mitral valve. So this the repeated transplantation kind of began to develop within us a comfort at looking at the left atrium through a right anterior thoracotomy. And during this time, we also went to visit Jan Schmidto in Germany, where we learned how to do minimally invasive HVAD implantation. And I'll just kind of quickly show you some of the procedure. The procedure essentially is a left thoracotomy with a median with a upper hemisternotomy. And so what you're looking at here, here's the head up here, here's the feet. This would be the atrium, and this is the aorta. This is the hemisternotomy. Then when we create our thoracotomy and marsupialize the pericardium, the left ventricle is an apex is projecting out of the wound. We then sew our inflow cannula cuff, connect the pump, and then tunnel the outflow graft to the aorta. Yeah. Well, how did this help us in minimally invasive, you might wonder? Well, again, it's what we learned when we were doing these VADs is how to work in tight quarters and essentially view the heart at different angles. But more importantly, there was outcome issues that we were seeing that really encouraged us to continue this pursuit, and that is how these patients were being recovered. If you remember when I talked about Dr. Petrasik's patients, less bleeding, more activity, less pain, and this is exactly what we saw with our mini HVACs. Less pain, less bleeding, quicker exit out of the unit. And so with these kind of signs and skills that we were accumulating as we were going on, we started looking for opportunities on how we can began performing minimally invasive mitral valve surgery. And if you are, I'm not sure if you're aware, but you're aware that there's an epidemic crisis in the country with opioids, but it is exacerbated in Middle Ohio. In fact, there are two bestsellers that I highly recommend reading. One is called Dreamland, and the other is Hillbilly Elegy by J.D. Vance, which essentially talk about this population that shifted into Middle Ohio and overnight became impoverished when the steel mills left and the drug use exploded in that area. So we were the recipients of these folks. We did close to 60 endocarditis per year, which is a lot. That is a lot. Maybe top 2 or 3 in the country. But anyhow, we viewed these folks as someone that would have a simple address to their mitral. It's replaced. You don't have to sit there and repair it and try to fix it. No, this is a replaced valve. And a young patient that you want out of the unit with as little pain as possible. And so we began to kind of think about performing those. Now I'm not sure what happened to my slide. Okay. Well, I lost some of my slides, but anyway, I was going to show you that we began performing we did a total of 20 endocarditis cases using a right thoracotomy for mitral valve replacements. All did well. All exited the unit quickly. Had the pain issue with these folks was not as, it was harder to tease out because many of them were dependent on opioids, so I can't really make a comment on their pain, but certainly far less bleeding and better activity. So let's, as we transition to kind of talk about minimally invasive mitral valve repair and or replacement, we can just kind of look at and develop some definitions of what we're talking about. What's a traditional approach to the mitral valve? That essentially involves 3 things. You do a sternotomy, you put them on bypass, arrest their heart, address their valve. That's the traditional approach. It has its advantages. We're trained on it. There's a comfort level associated with it. The whole heart is exposed. You have complete control of the circulation and oxygenation of those folks. But this comes at a cost, and that cost is there's more pain, there's more bleeding, and the dreaded sternal wound complication. In fact, if you were to poll cardiac surgeons and ask them what do you dislike, what complication do you dislike in your patient, it would be 2 things: strokes and sternal wound infections, something that we just have very little control. What about minimally invasive approaches? What are some of their advantages? Well, you can, in females, you can bury much of this incision in the inframammary fold. She can essentially, you can't see it. There's, of course, less pain, less bleeding. The visualization of the mitral valve, which you'll see in a minute, is just fantastic in the natural position. The disadvantages, these are technically, they can be technically more demanding. They're not appropriate for every patient. They're not appropriate for every team, and there's an expense associated with it, especially when robotics are involved. So what are these alternate approaches? Well, you know, the list can be daunting and long. There's thoracotomies, then there's hemisternotomies, upper and paramedian, there's robots, and there's ports and all that. So I've simplified it for us. You either are going to get a right anterior thoracotomy or you're going to get a partial sternotomy. Robots, in my view, are tools because you're still looking at the mitral valve on the right side. That's where the robot is anchored, but it's semantics. But these are approaches. And the other thing when you think about minimally invasive procedures is what are you doing to the aorta? Are you going to cross-clamp it, or are you going to fibrillate the heart? That's the alternate approach. So when we think about conventional versus mini, that's what we're talking about, incisions and what are we going to do to the aorta. In essence, what I'll show in this talk, that this is the same operation as we performed through a sternotomy, has the same results in durability, however we use different tools. Who's eligible? This is a moving target. It's really program specific. What do I mean by that? Take some of these contraindications. Let's look at thoracic surgery. Well, thoracic surgery comes in wide varieties. If you had a blebectomy, it's quite different than if you had a major resection with a decortication. So each program is going to have a comfort level of what they're going to consider a contraindication. But it's important to highlight that programs have to develop their inclusion criteria. And we'll see that when we're developing a program. So I want to very quickly demystify the mitral valve. You do not have to have Harry Potter-like skills to address this valve. In fact, Mark Gilnoff and a few other leading surgeons in the field speak of 5 techniques to address most of your degenerative diseases. And that is, if you have a posterior leaflet problem, you're either going to do a triangular resection or a sliding repair. If you have an anterior problem, you're going to have to use neocords. If your commissures are leaking, you close them, and everybody gets an annuloplasty. So just very quickly in pictorial format, if you have a posterior problem, you resect, you do a triangular resection, close it. If you have a multi-segment and or a high posterior leaflet, you do a sliding plasty. Commissures are closing, close up to 20% of the commissure without causing stenosis. Neocords are cords that are anchored in the papillary muscle to the leaflet edge. And then everybody gets a ring. Nobody escapes the operating room without a ring. Oh, so this is our first mini mitral at Ohio State. I'll kind of describe some of these pictures. So we first cannulate the femoral arteries. The femoral artery and vein. We perform our thoracotomy, and then these sutures are stay sutures that are pulling the pericardium rightward. And what really is astounding to me is that when you do pull the pericardium to me, because the heart is not a fixated structure, that the atrium is almost in the middle of this incision. So I'll show you. This is a right thoracotomy incision, which is right here. What you're looking at here is the aorta. This is the aorta right here. This is the integrate cardioplegia cannula. So it's just to demonstrate to you how much you're able to pull this heart into the field of this right thoracotomy. And unfortunately, I couldn't get someone to take a picture directly in there, but after you put the cardioplegia cannula, the cross clamp, you arrest this heart just like you do with a normal operation, with a conventional operation. Put your retractor, and the mitral valve is in place. I think the first time I performed this operation, the stunning thing was to look at the mitral valve in its it's in its relaxed normal position. You can see the entire thing. Not one portion of the annulus is obscured. It just looks at you in a very relaxed manner, and that was really quite interesting. So a few meta-analyses to look at. Dr. Chitwood is one of the leading robotic surgeons in the country. Had looked at a bunch of studies, and it essentially came out and noted that the effects of minimally invasive mitral valve surgery on morbidity and mortality compared with the conventional surgery demonstrated equivalent perioperative mortality, and there was a better bleeding profile, quicker exit out of the unit, and pain profile. And again, he noted, and that we'll see here in the subsequent, that cardiopulmonary bypass time in the mini mitral of various sorts was longer, and it did not affect mortality and or morbidity. This is really the largest meta-analysis, systematic review that is available. It's from the group at Maastricht in the Netherlands. Again, they demonstrated no difference in mortality between conventional and minimally invasive approaches. What's again noted in there, many studies that looked at cardiopulmonary bypass time, cardiopulmonary bypass time, cardiopulmonary bypass time, cardiopulmonary bypass time. None of these had an effect on mortality. Cardiopulmonary bypass time, although increased, had no effect on mortality. In reviewing this meta-analysis, which is quite involved, I took the largest study that they have and broke it down further. And the largest study came from Cleveland Clinic, Tom Mihaljevic, 2004, looked at 1,000 patients. Essentially, half of them were aortic and half of them were mitral, almost. And since we're looking at the mitral outcomes, it's interesting to note that perioperative mortality was unchanged. But if you look at his patient profile, the folks that underwent mini mitral valve surgery were healthier than those who underwent a full sternotomy. That's really the one thing that I drew out of this paper. Fast forward in 2010, Lars Svensson took these folks and added about 120 patients and did a propensity match, and again found no difference in mortality, better outcomes from pain, better bleeding, and lower length of stay, again with a propensity matched patient population. What about neurologic events? This is one that I have to put a huge asterisk on. So if you look at these meta-analyses, they tell you the risk of stroke when they compare almost 35 studies is about 2.1 versus 1.2, the minimally invasive versus the mini mitrals. A subgroup analysis of these studies finds that if you do cold fibrillatory arrest, which means the aorta is not cross-clamped, that was an independent risk factor for stroke. There was a threefold increase in stroke. A subsequent group looked at almost 100 patients and further defined things that are driving stroke, and they found that if you're old, if you had peripheral vascular disease, severe peripheral vascular disease, low ejection fraction, and you did not, and you used cold fibrillatory arrest, those were risk factors for stroke. And so Murphy came and in his group essentially evaluated all his patients that he was going to do a minimally invasive surgery on with a CT scan to look at their stroke rate. And when he excluded folks that had poor peripheral disease, low EF, the stroke rate was 1.6%. Now, let me just go back to this cold fibrillatory arrest. The group at Vanderbilt to this day continues to do minimally invasive mitral valve surgery using cold fibrillatory arrest. Their stroke rate on their latest study, which is soon to come out, is 1.7%. The reason I tell you got to put a big asterisk is all these folks, whatever they're utilizing, they're perfecting their techniques. So what they are doing, what they were not doing was flooding the field with CO2. So now they flood the field with CO2. They do not operate on anyone that has more than trace mitral regurgitation, and they operate in a wet field. So that aortic valve stays shut. It does not open. And they keep suckers away. They manipulated their procedure for them to drop their stroke rate. So the big point to take from strokes is that as you protocolize your patient selection, your stroke rate, in my view, is going to start mirroring the conventional What about bleeding, transfusion, and re-exploration? When you compare those to conventional therapy, so in the robotic group, 2 studies showed that there was no difference in bleeding, transfusion, or re-exploration, but there was a decrease in chest tube output. Two studies showed a reduction in all. In the thoracotomy group, 3 out of 10 studies showed that there was a decrease in all, and the remaining showed that there were no difference. So, in essence, the bleeding is better than the standard therapy, and in most cases, in some cases, it is equivalent. What about atrial fibrillation? 4 studies showed that there was that looked at atrial fib, found that there was no difference between the group. Infections, there was a significant difference. Sternotomies. This is actually a very important point, because a thoracotomy incision gets infected. It's much, much easier to address than a sternum that gets infected. An incision off to the side can be managed with simple wet to dry dressing. A sternum that gets infected needs an operation in flaps to address. And then the pain and life quality profiles, as you would expect, as you limit these incisions, no matter what kind of operation you do, you have better quality of life and less pain. In fact, many of these studies showed that there was a return to activity almost a month sooner than the sternotomy arm. The median length of stay was around a day in the ICU. This is ICU stay. Lastly, this is the last study we'll look at. I don't want to overwhelm you with all these studies, since there's just a lot, and they're all almost kind of saying the same thing. But this is particularly interesting because it looked at the elderly. It looked at folks that were age 70 and above and did propensity match comparisons to them. The only difference that Fred Moore and Leipzig found, that in the sternotomy arm, there was a higher rate of arrhythmia and pacemaker need. And if you read his paper, it's basically about 2 lines. He's unsure as to why, but he speculates that because the thoracotomy approach gives you better visualization of the A1 area, that there was more precise placement of sutures. This is his thinking as to why there was a difference in the sternotomy arm versus the minimally invasive. And he concludes that minimally invasive mitral valve surgery through a right lateral thoracotomy is at least as good and safe as standard sternotomy approach in the elderly. What other benefits can we derive from this thoracotomy, and why are we proposing that we build a program? Because it's not only going to address your mitral valve issues, it's going to give you an opportunity to further expand into hybridized procedures in what I call the zebras. But what a zebra is, for those that didn't go through general surgery residency, is these obscure diseases or these obscure things that you hardly ever see. And I'm going to show you 2 cases where this was utilized. Dr. Lamellis, and in fact, at the STS this year, there was during the technology, it's a day that is dedicated to technology, and it's usually the day before the meeting starts. And there was close to about 6 or 7 presenters that were presenting hybridized approaches to the mitral valve using the SAPIEN valve. One person approached it to the apex of the heart, where he harpooned the anterior leaflet and deployed the valve through the anterior leaflet. In MAC, you were not allowed to take pictures through any of these sessions. He performed, I think, 4 total procedures like this. These numbers are very small because folks are starting to do this. But Dr. Lamelas has published this this case report where he had someone with a previous aortic valve, and subsequently the patient had back. And he performed this operation through a right thoracotomy where he exposed the mitral valve, excised the leafless, and deployed a sapien valve. And again, you know, if we're not facile with these approaches, it's going to be more difficult to perform these procedures that are quite honestly indicated and more appropriate in these folks. Someone that has almost circumferential MAC is going to be a treacherous person to take care of, because as you decalcify this MAC, you're going to run into a risk of an AV group dissociation. This kind of procedure completely takes that off the board. So I'm very encouraged by it. So about a year ago, this is the zebra, if you will. About a year ago, Carl had this, Dr. Moody had this patient that came to him. He's a 30-year-old gentleman with a double outlet right ventricle that was repaired in infancy. And he came to him with a ruptured mycotic aneurysm. That gentleman was an IV drug user. And so for those that perform sternotomies, is this going to be a safe sternotomy to perform? Is this person going to, I'll help you, I didn't mean to do a pop quiz. The answer is no. You cannot perform this sternotomy safely. You have to really arrest this heart. You have to bring this patient down. You essentially have to put him on cold tubatory. You have to circ arrest this patient before you can even address the sternum. So how do we do that safely? You can't just start pulling a patient because his ventricle distends, and with that comes ischemia. So we use these alternate approaches. A left thoracotomy is performed. You vent the heart. Another alternate approach is cannulating the axillary artery. And this allows you to cool this patient, vent his heart, put him on bypass, and in a very controlled fashion perform a sternotomy. So he had a sternotomy performed and a root replaced, and these are Cabral attachments to his coronaries. About a year later, this gentleman returns with an infected biobental, the biobental that he received. So again, to help you, this is the Cabral here. Is this going to be a safe sternotomy to perform? Yeah. So yeah, okay, good. We're on board. So again, we're utilizing these alternate approaches once again. We do the same approach here on the left and cannulate the axilla, but now we open the right side so we can very carefully take down this attachment this biobental that's stuck to the sternum. And that's essentially what happened. This turned from a very difficult operation to a very controlled operation when you're able to use these different approaches. So the heart was vented, it was cooled, the person was placed, the right thoracotomy was performed, the biobental was peeled off the sternum, and then the person was circ arrested, sternotomy performed, procedure completed. And here you see a homograph done with the Cabral. So where do we move from here? How do we build a sustainable program? Well, you need equipment, you need material, you need personnel, and you need a plan. What's interesting is I did not find anyone that wrote on how they built their program, but there was little snippets here in there on how they formed some portions of their team, and none other than Mark Gilnov had an excellent paper on this where he looked at his robotic mitral valve experience. And in it, he stipulates that his success in building his mitral valve surgery program was all algorithm driven. So let's look at his algorithm. Essentially, can you see that? So he looked at you. Did you have a reoperation? Yes. No robot for you. Do you have severe MAC? Yes. No. LV dysfunction? Yes. You don't get it. And so he got this algorithm that he has developed, and whenever you met the inclusion criteria of this algorithm that he had, you moved into a robotic procedure, and he had fantastic results on his 1,000 cases that he analyzed. And interestingly, his stroke rate on this, since we're talking about stroke, was 1.6%. So essentially, as we think about our program and how we're going to do it, we're going to have to do the same thing. We're going to have to figure out how we're going to select our patients and how we're going to develop our algorithm. Team training, we're going to learn from established programs. Addressing challenges. Challenges are going to arise when you do new things, and especially when you do minimally invasive procedures. We can't kind of run away from challenges, but address them. We need institutional support and ongoing quality improvement and result review. So some final thoughts. And I hope I've demonstrated that minimally invasive mitral valve surgery is safe and a viable alternative to sternotomy. It's really the same procedure using a different approach. Alternate approaches in cardiac surgery are expanding the spectrum of diseases that we can treat, especially in hybrid procedures that I mentioned. And there's a tsunami of these procedures coming. I mean, we just went and did 10-dyne training. I'm sure there are companies that I'm not even aware of. Paul can probably speak more authoritatively on this. There is a tsunami of technology that's coming down the line, and I think that we should be in position to utilize these in a hybridized approach. And finally, we can and we should be building a program.
Thank you. A quick reminder to folks on the phone, if you press star 6 if you've got a question. Otherwise, are there questions in the room?
Thank you very much, Sammy. Hey, is there anything we can do to help to decrease the potential risk of a new program through non-invasive imaging that you might not do otherwise?
So what I'm employing much of the things that Mark does. So Mark essentially does a complete CT scan, and we look at your vasculature. If you have heavy calcifications of your femoral vessels and or aorta, we shy away from that. Secondly, we look at echocardiograms to look at the root, and that's essentially what we're doing. I'm not sure what else we can do off the top of my head. I really get a complete CT scan that looks at calcifications, because strokes are extremely important. I'll tell you, the question I had when I was looking at strokes is how many of these strokes are debilitating and how many of them are not, and that's very hard to tease out. There's only one study actually that teases it out. There's one study that looked at it. They had 3.1%, it's an older study, 3.1% total strokes, and I believe the number was 40, I can't remember the exact numbers, but 1.0% were debilitating strokes, and 1.7% of the 3.1% were non-debilitating strokes. So that's kind of what we're doing, is that we're getting CT scans on everyone along with echoes. I can't think of any. Yeah. Oh, sure. I'm sorry. I missed it. we do get the whole CTA.
So congratulations, excellent presentation. Now, didn't touch on the coronary side, but there's a lot of excitement over several years about doing some more hybrid procedures and combined minimal invasive. How does that apply the accesses to the coronary side?
Yeah, so the coronaries is the mid-cab, which is essentially you're taking down the lima and performing a off-pump bypass the lima. Now, there's other folks that are performing these procedures using robotics and doing a complete cab. And there's one or two guys, I think there's the guy in New York that does a complete cab using bilateral thoracotomy. So just to be clear, if we're talking about mid-cab, the approach that is widely used now is doing a robotic takedown of the lima, left anterior thoracotomy, and bypassing the LAD and stenting the rest. If you're talking about the rest, well, they're fully revascularized. So the only true hybrid procedure in coronary surgery I see, certainly this is in my limited view, is when you're doing an off-pump lima to LAD or another vein graft off of that to a lateral wall vessel. That doing right coronary bypasses, I can't think of many people that are doing it. There's one guy at the University of Chicago, and I know another person in New York. I'm not aware of. Are you aware of anyone, Ben, that's doing it?
No. Doing coronaries in a non-sternotomy approach is not developed to the point where it's utilized to the masses. Like anything else, when you're developing new techniques, you have a few innovators, and then you see if you can develop the tools and the techniques so that it can be widely disseminated. If only one or two people are able to do it, then it's not reproducible. So the coronaries has been like that with robotics and other non-sternotomy approaches for years. And to be frank, I don't know that it makes a whole lot of sense, because when you're looking at these you look at outcomes, the only thing that really makes a difference is the IMA to the LT.
Yeah.
And so if you compare stenting versus all these other very, very technically challenging approaches with unclear added benefit, you wonder whether or not it kind of makes sense. This is very different, where you're doing the same operation with a reproducible approach to it through these non-sternotomy techniques that makes sense, because it is translatable to more institutions. Now, I want to also emphasize that despite that these are non-sternotomy approaches, we still have the potential for complications that are related to open heart surgery as they come. So we can still on occasion have preservation issues. We all have them with sternotomy or a so we want to, as we move forward with programmatic development, it's very easy if you have complications to associate it only with a different approach. But we just have to, as a group, be careful. We have to be careful as surgeons moving to these fields, but as a program and as a team, understand that complications occur in the absence of sternotomy, and not just using this non-sternotomy approach as the indictment and the adverse outcomes.
Great talk. You had one slide where you say demystification of the surgery. Was it a talk where Ted Feldman tried to demystify one thing, which was when we see patients, they're relatively asymptomatic, but by the guidelines have maybe a 2B indication or 2A indication to have mitral valve repair. Our guidelines, correct me if I'm wrong, says you have to tell me as a surgeon that you have a 95% chance of repairing this valve, right? He looked at the data of all surgeons in the United States. I think there's only a handful of surgeons who can claim close to 90% repair success. It's just not there, right? So my question would be, number one, what is the realistic number for a repair versus replacement in a patient when we refer them? And number two, if you then go minimally invasive at this point or in the future, would that change anything? Should we? What is the real rate actually? What you think?
Sure. So, like you said, you're going to have to ask me what I'm capable of. Well, I will tell you that if it's a simple P2 prolapse, I can tell you that I have a greater than 90% chance of repairing this valve. The more the complex the procedure, then the more gray hair surgeon you need to guarantee that for you. Now, I will say, okay, or no hair. Oh, well, that doesn't work. But no, seriously, the majority of our prolapses are located on P2. The majority of these repairs are done on P2. Now, when you get these Barlow situations and you having to create neocords, this is when it becomes slightly more challenging. But we have small technological advances truly helped us. And Cordex, which is by Cryolife, has pre-measured cords for us. So it made the neocord mystique almost gone. In fact, we've done, is it 4? I think it's 4. We've done 4 mitral valves using, on one we use 1, 2, on another we use 9 neocords. Now, I wasn't planning to talk about this. There's also another page being turned on mitral valve, and it's respect, not resect. And it's the whole idea of using neocords on the posterior leaflet. The anterior leaflet, we know we can do it. But now we're kind of moving into this era, if you will, where we're using neocords on the posterior leaflet. And that has become my go-to approach to it, because it can address a single segment, multi-segment. I just look at where the cords are ruptured and or elongated. I measure, and I put a neocord there. What we're finding out is, as opposed to the resection where you're freezing that posterior leaflet, you're dropping the posterior leaflet, and the anterior leaflet is basically your valve. What we see with neocords is we have a dynamic posterior leaflet. Both of them are doing this. The key is that posterior leaflet can't do this to the anterior leaflet called SAM. And this is really what's exciting about the neocords, is that they're going to help us restore the valve to as close to its natural state by making it do this rather than making it do this. Because we're worried about SAM. This whole idea of dropping the posterior leaflet out of the way is it won't push your anterior leaflet and cause SAM. And so as we become more facile with these approaches, then I can tell you, with some certainty that I could perform a successful operation on this valve. But realize that as the complexity of the mitral valve increases, the ability to repair this valve successfully is going to drop. So that's how I kind of look at where the prolapse is and how complex it is, and I tell you, I think I can do it.
Just one comment to it. Obviously, when we talk about the success rate there, there's learning curve to everything, as we know, and initially some of the complications will happen, and that's looking at our for example, heart failure programs that we developed, looking at our ECMO program. Every ECMO program starts with 10-20% limb loss with the first few years. You introduce the safety measures, patient selection, and you introduce protocols that help you avoid complications. And last 3 years we didn't take a single. So obviously those are the things that we will encounter, and we have to, I think, iron them out. But there's some learning curve that we have to accept. That's for sure. In terms of the neocords that Sam mentioned here, the really huge benefit of it, as we perceive it, and there was a huge debate currently ongoing, and there was a great debate at our meeting at STS between Dr. McCarthy and Dr. Gami from Maryland about those two techniques, resection and resuspension with neocords. The neocord repair is in a way very easy because you look at the valve, you find something that is broken, just replace it. It's literally like replacing a broken part. There is no the idea of planning the whole mitral valve repair and from the very beginning, looking at multiple prolapsing segments and 5 jets, and you need to know how to make cuts like a seamstress and know how it's going to end. That kind of this part is gone because you find 1 or 2 elongated or ruptured cords, and you just replace them. You put the 2 neocords, and then you inflate the ventricle, and you look what happens. If you don't like them, you take them down. You didn't do anything. You didn't burn any bridges. The only thing that, according to what the data that Sam presented here, is that you have to make sure your myocardial protection is good, and this is not going to be a very lengthy procedure. But even if listening to to one of the leading programs, which is the Cleveland Clinic program, during last mitral conclave in New York, they said that they go back and they re-repair the valve. They add, by adding more cords 2 to 3 times. Obviously, patient selection is very important. Young patients can tolerate more than 1 cross clamp, but the goal is to repair it, and it's very repairable. It's very reproducible, and many programs, training programs in the country that are focused obviously on training new cardiac surgeons, say that it is a much easier repair to train new surgeons, neocords, because it's a different paradigm.
Because if your repair doesn't work, you haven't lost any. You could always go over a second. You just take out the neocord. These are, just trying to find a picture for you on them. They're essentially pre-measured cords. They're cords that are made at 12, 14, 16, 20, and 22. And what happens is there's a measuring tool that you just use it, you measure, you put it in. If you don't like the suture, you just take it out. You haven't hurt the valve, you haven't done anything to prevent you from doing excuse me, a more traditional repair with section. And moreover, you can just add cords. This does not prevent you. If you put 1 cord, you can just add these cords. These cord limbs comes with 3 cords. It's an anchor, the capillary muscle, and then you anchor it to the valve leaflet. And you can have three separate arms coming out of this. So you could put in 1 suture, you can have 3 neocords.
There's two different things. One is the problem with access, and if you have a minimal support, maybe you have to convert that. How often would that happen? Then the second is the actual procedure itself and what you're doing. So
Sure.
Just in consideration of access, assuming we think it's appropriate to go to surgery, how often do you have to convert, and how limiting is this anterolateral exposure?
That's a great question. So as far as visualization of the valve, I really wish I had a picture. It's incredible, the visualization of this valve. Visualization is rarely the reason to convert. The reason to convert is you're worried about cardiac protection or you're worried about the aorta. So we cross-clamp the aorta here. We do this traditional operation using a different technique. If that aorta looks suspicious, if it's bruised, if you're concerned about it, I have no problem converting. I want to convert. I want to look at the aorta. For me to do a 2-hour procedure and not recognize the dissection. The other issue is you say, well, you have active transesophageal echo. Well, the transesophageal echo is not going to be able to view the upper aspect of the ACE. So if at any point there's concern about what's going on with plegia and if there's concern with that aorta, I convert. These are the 2 reasons that I would convert. As far as visualization, I've never had problems with visualizing. But you are right, visualization is another one to convert. You cause an injury. You cause an injury to the annulus. You need to convert. You cause an injury to the coronary. One of your sutures clips the circumflex. You need to convert. if I may say this very gently, conversion is not the same thing as a complication. Putting your head in the sand and saying, we're all good, will lead to a complication if you don't convert. You've got to be ready. We convert all the time at various surgeries. In general surgery, you try to do a ventral hernia repair using laparoscopic instruments. If that laparoscope insufflates your sub-Q, you lose domain in that abdomen. You can't see anything. We convert. There's very little criticism in general surgeons converting from a laparoscopic to, you name it. You're doing a knee operation, you're trying to do it thoracoscopic, using scopes. You can't see, you can't get out the cartilage. They touch your knee. But for some reason, we've confused the two in cardiac surgery in that, oh, they converted. Well, listen, you've got to convert. You can't be scared. The worst thing you do is to become fearful and not convert. You have to convert because ultimately you've got to do the right thing for the patient. These are incisions, and overwhelmingly they were all healed. But that's where we see most of our conversion. I don't know if you have any other thoughts. Visualization is spectacular. I don't want to use hyperbolic language, but it is just spectacular on how much of the value you can see. And it's not only me saying that. You know, Fred Moore he's very famous in this stuff. And this is one of the things he'll highlight, is that when he does many thoracotomies for mitral valve, he can't get over the visualization of this valve. And I will tell you, I've never visualized the mitral valve any better. It just hangs. It just hangs in such a natural state, and it only requires one instrument.